Thank you. Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held today, Monday the 19th of May 2025. For those present in the room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing it does not disrupt the meeting, the business of the meeting. There are no members of the public present at the moment. For participants in the room, please raise your hand to indicate that you wish to contribute. Then invited to speak, press the red button on the right-hand side of the microphone unit. Please remember to turn your microphone off once you have finished speaking. Please ensure that all mobile phones, laptops and other devices are turned to silent. I don't think we have, we don't have anybody remotely joining us, do we? Thank you. So item 1 on the agenda, we have apologies for absence.
We've had apologies for absence from Councillor Polly Andrews, Councillor Jenny Bartlett and Councillor Simeon Cole.
And item 2, names.
And Councillor Louis Stark is present as the name substitute for Councillor Polly Andrews, and Councillor Rebecca Tully is present as the name substitute for Councillor Jenny Bartlett.
And I welcome you all. Thank you. Item 3 is declarations of interest. Do any members wish to declare any interest in the agenda items? No. Item 4 is to adopt the minutes from the last meeting, and that was held on the 31st of March 2025, included in the agenda pack, pages 11 to 21. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign these minutes as an accurate record? And it's Councillor Davis and Councillor Thomas who are here at that meeting. Thank you. Item 5 is questions from members of the public. The committee has not received any questions on this occasion. And likewise, item 6 is questions from members of the council, and the committee have not received any questions on this occasion. Therefore, we move rapidly on, and we are going to look at adult mental health inpatient and rehabilitation services, and this is a redesign that's been proposed. And today we have Sue Harris and I think it's Matthew Hall, and they're going to introduce this item on our agenda. Over to you, Sue.
Thank you. Can I check that's working? Indeed. Great, thank you. So yes, thank you ever so much for having us this afternoon. So yeah, for those of you who haven't met before, Sue Harris, Director of Strategy and Partnerships, Herefordshire and Worcestershire Health and Care Trust. I'm going to let Matthew introduce himself, but he will be carrying the lion's share of the agenda. So we obviously have sent round the paper in advance so you can sort of see the scope of the programme of the work that we're looking to talk to you about today. It's quite a long-term piece of work, but we're clearly at a point now where we wanted to get your views and to make sure that we haven't missed anything. And as we move forward to more formal options being considered and going out to consultation, your support about how best to do that. So I'm really here for later on with questions around the service change process that we're in from an NHS perspective, engagement, public involvement, and then really to look at the onward timeframes of the work that we've still got left to do. So with that in mind, I was going to hand to Matthew, who's going to give us a brief overview of where we are in the work programme, what it entails, and some of the next steps.
Thank you. And I'll perhaps start with a little bit of context as well. The paper speaks developments in mental health inpatients and rehabilitation for working age adults, which in due course will have some bearing on services provided in Herefordshire. There's two related schemes discussed in the paper. One is very much a quality improvement scheme focused on improving treatment and patient pathways on acute mental health wards, with the outcome of eliminating inappropriate out-of-area placements, so making sure that local people can have a local bed when they need it. That scheme is a scheme that's kind of drawing to an end now and doesn't have an immediate bearing on services provided in Herefordshire. The second is a longer term piece of redesign work for mental health rehabilitation, which I will talk mainly about. Just to contextualise it, I suppose, being admitted to a mental health ward is a rare event. So we provide mental health services to around 20,000 people across the 2 counties each year. And every year, about 450 people are admitted to a specialist mental health inpatient bed. And of those, only 30 to 40 require a rehabilitation bed. So for Herefordshire, that's about 120 acute admissions and only about 10 rehabilitation admissions. We've currently got 50 acute beds. So we've got 1 ward at Stonebow and 2 at Elgar, supplemented by a 9-patient intensive care unit, which is at Elgar. Just for completeness as well, we've just completed the complete refurbishment of Stonebow. So all 3 wards at the Stonebow unit for Herefordshire patients, older adults and working age adults, have been completely rebuilt to modern standards. So that's a piece of work that's been a great benefit to local residents. Admission to acute care as well. The other thing I'd say about it is it's only something that we consider when community care cannot be safely provided. So if you're admitted to an inpatient unit, you'll probably be in there for 25 to 30 days. For our rehabilitation units, these are units for people that have got persistent, challenging conditions or are highly disabled by their mental health condition. So they need help intensively to regain skills. So admission is often for a year or longer. In Herefordshire, we've got 10 beds at Oak House, and we've got 2 units in Worcestershire as well. As we've been looking at our rehabilitation provision across the 2 counties, we've been adopting what's called the Getting It Right First Time methodology. So that's supported by the Royal College of Psychiatrists, and we've been using the NHS England commissioning guidance to look at our rehabilitation mental health services and compare those to the national standards for mental health rehabilitation. What's been evident very early on in the review is that our local rehabilitation services are not the best fit for the needs of our current population. So in national guidance, there's 2 levels of rehabilitation services that should be provided for local people. One's called Level 1 rehabilitation. That's community based. That's for people who need a longer term piece of care after acute inpatient admission, but can have it either in a fairly open ward environment or can have it in something like supported housing with community specialist health in reach. The second is what's called intensive rehabilitation, and that's what was sometimes used to be called locked rehabilitation. All the units we've got across the 2 counties are somewhere in the middle. So they're a bit more than what you'd expect for community-based rehabilitation, but they're often not of the right design or to the right specification to provide care for the more challenging patients that we have that require rehabilitation in both counties. Now, the implication for that is that we end up placing those patients out of area. So at the moment we've got 9 patients placed out of area, some of those many hundreds of miles away to get a specialist rehabilitation bed. And we've also got a fairly large number of patients. Out of our 50 acute inpatient beds, we've got 17 patients at the moment who've been in acute hospital more than 60 days. And many of those would benefit from rehabilitation. So they don't need to be in acute care anymore. They should go to a rehabilitation setting, but we don't have the right profile of rehabilitation beds provided across the 2 counties. So all of our resource was designed 15, 20 years ago, sometimes longer, and the needs of our patients have changed considerably over that time. Another factor that we've been considering in the redesign is around Oak House itself. So Oak House is a 10-bedded unit. It's based in a Georgian house down by the river. We've got a lease on it, so we don't own that property, and the lease ends in 2027. We made good use of the building, but it's got considerable limitations. It's got limitations with line of sight, so it's a Georgian house, it's not a modern ward. It's got accessibility problems, again for the same reasons, and also we cannot fully de-risk it. So when you're building an inpatient environment, you want it to be what's called ligature free. So you want an environment where people can't harm themselves, and we can't adapt Oak House to make it in that way because the building's too old, and it's a listed building as well. There's certain things we can't do with it. The redesign program that we're working through at the moment started in January 2023. It's taken time because we've been following the major change process, and the emphasis in that is on continuous consultation and co-design. The ideas that we've generated with stakeholder partners have been taken through a refinement funnel. So we've taken things from a large range of all possible solutions through a desirable criteria funnel, and now we're at the developing options appraisal stage. So we're nearing the end stages where we're presenting options that are capable, when they've been fully worked up, of going through consultation. We've been working with service users and stakeholders formally and informally at all stages. So on the design group, we've still got 2 experts by experience. On the completion of our options appraisals, we're in the last few months of working through the details of that at the moment. We'll take it through to something called Clinical Senate. So Clinical Senate is an expert panel convened by NHS England of clinical experts who, when you're proposing a major service change, you describe it all, set it out to them, and they'll give you a viewpoint whether this is a service change that's good to go or whether it needs further refinement. So public consultation will follow that, and changes to service provision from late 2026 onwards following public consultation. There's 3 options at the moment which are currently being worked up as an options appraisal. There's some variance between them, but they've started to coalesce in the middle of these are sensible ways in which we can meet the needs of the population. All of them involve closure of Cromwell House in Worcestershire, which, like Oak House, has got limitations on its usage. All of them reduce the number of beds that we've got in our current rehabilitation units, and all of them use the resource from closed units to reinvest in level 1 community-based rehab, so more community-based rehabilitation, including supporting supported housing. At the moment, all of the options also propose the conversion of the Hillcrest unit, which was a unit we had in Redditch, which was used as an acute ward, which we've moved out of into more modern accommodation. Since writing the paper, somewhat of an update, we would not be using Hillcrest as a level 2 unit. We'd be looking to work with an independent partner, and the reason for that is we've undergone a feasibility assessment. It's an old building, it's not fit for purpose, and the cost of the capital works is prohibitive, really. It's not a cost-effective thing to do. So we're at the point where options appraisals are being developed to go to Clinical Senate and subsequently to public consultation. The part that would bear on public consultation in Herefordshire would be possible closure or change of use of Oak House and the reprovision of that type of service as a community-based service.
Okay, thank you. Thanks, Matthew. There's an awful lot to think about there, isn't there? We've all had these papers, and we'll get into the questions, I'm sure, in a minute. But first, Councillor Gandy, you're the Cabinet Member for Adults and Health and Wellbeing. Would you like to say anything?
I welcome the fact that have improved Stowe Row, because I know when we had the inspection, there were issues about the fact that you've got mixed wards, and that wasn't acceptable. I'm interested only because I worked at the Alex, so I know Hillcrest very well. I'm interested to know how old a building has to be classed as old, because it's not that old in the scheme of things. I mean, it was built after the Alex was built, probably not long after the Alex was built, but it was certainly built in my time. And I would have thought there was an opportunity for some use for it going forward, because there's quite a lot of land there.
Shall I answer? Yes, we'd have hoped so, and our original thinking was, well, okay, we've been using this as an acute ward. We should be able to adapt it as a rehabilitation environment. There's two main challenges we've had with the building. One is that it doesn't provide ensuite accommodation. So that's the standard now for all mental health accommodations. It has to be ensuite. That's especially if you think of somebody in a rehabilitation environment. This is their home. So you wouldn't want to be sharing a bathroom with other people, and all the bathrooms at Hillcrest are shared. So the rooms are also very, very small, the bedrooms. When we've looked at how we would get the number of bedrooms out of it and add in ensuite bathrooms as well, the number in the footprint started going down and down and down and down, and we realised we were going to have to build an extension to what's already a large building in order to do that. So that's problem one, is it wasn't big enough to get the ensuite bedrooms in. Problem two is that the building's carbon footprint is completely non-compliant with modern building standards. And if you're uprating a health building now, they treat it as if it's a new build. So you have to comply with kind of modern kind of net zero standards. So we'd have to fully retro-insulate the entire building as well as building an extension. We were looking at a cost in the region of 10 to 15 million. And this is the kind of cost that we'd spent on refurbishing 3 wards on the Stonebow site. So to spend that amount capital on a single building, and at the end of that you still haven't got what's optimal, it was never going to be a good proposition. So we'd have liked to reuse it, but practically it hasn't been possible.
Can I just add as well, it's not empty. So we've got community services operating out the front. So it's not like it's a building that's not in use just for inpatients. We can't find a way to make it work in the way Matthew describes, but it is well used in terms of clinic space, and the community teams, crisis teams, and some of our specialist mental health teams operate from there as well.
And I thank Councillor Gandy for putting the Worcestershire side of it in our perspective as well. Yeah. Right, before we move on, can I just say, you know, thinking about locations and buildings, we obviously have had the regeneration of Stonebow unit and the Mortimer ward, is it, that's been revamped, etc., because we have to have specific areas for different people. It may be something that this committee would welcome, to have a visit down to the Stonebow unit now that it's complete. I know the works took quite a long time and an awful lot of money, as we well know. And we also, I know where Oak House is, and I know that it's a building that's not really fit for purpose. And I don't mean fit for purpose for the people, I mean fit for purpose as a building. It's a house, and you've got many small rooms which don't really support what is supposed to be being done there. So I had a hand up by Councillor Thomas.
Listening to you, why we let it get to this point? It seems to me to be, I fully appreciate that mental health is the sort of Cinderella of the health service, but why have we let it get to this point? Why have we not invested in decent buildings some time ago?
The type of the types of investments that we've been under to take have been because there's been the availability of national capital. So obviously, as a trust, we're limited in our capital allowance. So each year we have to put forward capital schemes, and we're given permission to undertake them. The type of schemes that have led to the rebuilding of the Elgine unit and also Stonebow, they would have been, they'd have used up our entire capital limit. So we had to wait for a national scheme to be available. For the rehabilitation services, we were prompted to undertake this because 5 years ago a new national set of guidance was published, and it was that guidance which we reviewed ourselves against. So we've come out of this because of the national guidance and us benchmarking ourselves against that.
Okay. I've got 2 questions. Can I kick off with first, if that's okay? What is the overall strategic objective of the redesign and improvement programme, and what are the drivers? And I suspect I know what they are, but I just wondered if you could tell me or us. And what evidence, for example, clinical outcomes, occupancy trends, CQC reports, has informed the decision to redesign the services?
Okay. So our overall strategic outcomes, they're about preventing long-term disability in people with severe mental health problems. The type of people that we're bringing through rehabilitation, if they don't get the right type of support, they end up with a lot worse outcomes than the general population. So they end up in residential and nursing care and living far less independently. If you have a successful rehabilitation program, you can bring people, after regaining skills, back down through the ladder through supported housing, and often into their own tenancy with community support. So that's what we're aiming for. In terms of benchmarking, so the Getting It Right First Time program set out a kind of series of benchmarks to say, okay, what does your local provision look like? How many people have you got placed out of area? Should you be looking at placing those people back in area? And the answers to some of those were, as I've said, our local provision doesn't match our needs profile. The national guidance on commissioning of mental health inpatient services as well was very explicit on what should be provided at each level. And again, we found deficits there. We don't have the community-based rehab that we should have. And the reason we don't in Herefordshire and Worcestershire is that the money that would be spent on community services in other places is tied up in beds. And it's tied up in beds in units that also, they're doing a good job, but they're not doing as good a job as they could do if we unpack that and made that a community-based resource. And one big gap that we identified was that if somebody needed that intensive support, they were often going to go a very long way for it. So at the moment, the 9 people we've got placed out of area, they are placed in with 4 different providers in 7 different locations, up to 150 miles away. So really, at the very least, we want to consolidate that provision, work with a single provider, if at all possible, to a set of standards that we're dictating locally for local people and hold people to account for the outcomes. It's a very difficult thing to do when you're working with a dispersed patient group.
Thank you. And I think as elected ward members, we all want the people of Herefordshire to be able to stay as close as possible. We all appreciate that transport, etc., is really important, and having that family connection if they want to have it close to home. Just one thing before we come to Councillor Davis. You keep mentioning getting it right for the first time, the gift. And I just wondered, can the Trust provide access to this pre-consultation engagement report and other relevant documents so that we can have a look at it at scrutiny?
Yes, we can supply all supporting documentation.
Thank you, that would be really helpful. Councillor Davis.
Thank you, Chair. Thank you, Matthew, for that presentation. The out of areas patients we have, the 9 patients you mentioned, is there an associated cost impact that to us, or to yourselves, or is there a quid pro quo where we have out of area patients ourselves in the facilities we do have? I was just wondering if there was a balance there, or whether there was just a negative impact on us as far as cost goes.
Whatever rehabilitation provision is commissioned, it's going to cost a certain amount per bed day. Some independent providers are very good value, and they're providing at near to NHS rates or very competitive to NHS rates. Some are poorer value. Our discussions with ICB currently are about consolidating provision so that we're getting the best possible value in one place. So whether it was something we directly provided, so that was our original view, let's try and provide this at Hillcrest, or whether it's provided by an independent provider, the cost is likely to be similar.
Councillor Stark.
Thank you for that. I tried to look at the 3 options, and I tried to work out which one would be the best, and I couldn't. And then I went back to the guidance in terms of the and we statements about value, accessibility, humanity, equity, therapeutic and collaborative. I was a bit surprised that when you put together the 3 options, you didn't actually try and give some sort of analysis of what that would mean for these 6 statements in terms of the patient at the heart of this, because that would have been a far better sort of test for me to actually decide which option would have been the best for us, because I couldn't tell you now which one would be the best because I don't have enough evidence. Are you going to do that? Because otherwise I think anyone from outside coming to this, I don't think they'll be able to give you a view on which option would be the best, particularly for the residents of Hertfordshire, because in some of the options you're closing some of the level 1 patient units, but I know you're also replacing it with this rehabilitation unit. And I do think the six statements do need to be tied into that. I don't know where we go with that, Chair, because we won't necessarily get an answer today, or will we?
I think I was just going to say that's really helpful given where we are in the process at the moment. So the 3 options are now being developed, built up, and then we go into that sense check that Matthew talked about with Clinical Senate, which is an NHS England assurance process. It's another checkpoint. We also have to go through a different gateway process. So the more that we can pull through now to build up in the way you've described, that's really helpful, so we can include that as we move on through.
Because it seems to me some of those statements, such as accessibility, goes to the heart of this issue of patients being out of area, for example. And it forces you to face that sort of issue, and I think that might direct you in a way that you might not have been thinking about being directed up to now. And of course it's in the NHS guidance, so I assume somebody somewhere will come along and test you on it anyway. Right. Thank you.
One of the other things I was looking at is between option 1 and option 3. They both have an external partners option on there. And I just wondered, are you using external partners at the moment?
At the moment, we're seeking an external partner. What we'd ideally be looking for is a supported housing provider who was willing to take a profile of people that had a slightly higher level of needs with in reach from a community rehabilitation service. That's what we're seeking at the moment.
we'll come back to you in a second. And the other side of things, I just wonder regarding, you know, not sending people out of county. I'm sure Worcester are doing it as well. So is there any opportunity that we could build something, Hereford and Worcester border, so that people don't have to go out of big county or big region, so that, you know, they get a better offer? And I also appreciate that we have to work with the ICB and One Herefordshire, etc. So I think there's a bigger picture to all this regarding funding and support.
Absolutely. When we've gone through a quite a long consultation process, you're looking at one end where a wider range of options come down to a smaller range. One of the things that we looked at quite early on was to see whether something could be built, or an existing building or site that we had could take a new build or a large adaptation. In terms of time frames, so in terms of through land acquisition planning and the capital cost involved, that quickly fell out of the running. Even if you had the capital, you're talking about a very, very long lead in for a new program like that. That's why we ended up with the adaptation of the only unit that we had, which had a similar usage, and even that's fallen by the wayside. So it'd be fantastic if we had the time and we had the capital.
So has that actually been completely taken off the table?
I
know it's not going to happen quickly because nothing ever does, but you know, for say 10 years time, you know, things aren't going to get better. You know, we have to try and foolproof things, and spending money reconfiguring places and then moving to a different place, you know, that all adds up. And you know, ultimately, if we had a purpose-built joint county area, a flexible space. Oh, it's just me with my wouldn't it be nice head on. Councillor Stark, did you want to say something else?
Yes. On the surgical side, we don't try and do everything in one area. We've got specialist hospitals around in Cambridge. If you had a real heart condition, they would send you to Tarenbrooks. And I know someone that I know who had open heart operation, had to go to Birmingham. Is it realistic to expect to deal with every patient in every degree of mental health in terms of just within the trust itself? Or should you not be looking at providing the best service for those that you can't provide the best service for, and accepting that for some particular acute cases, you may very well have to follow the surgical route and send them somewhere else?
Yeah, we do have similar arrangements in mental health. So if you think about the specially commissioned portfolio, so for example, I'd be eating disorder beds. We don't, as a trust, have those. They sit in our regional portfolio, and obviously we have to work really well with the providers of those beds. So we've got mother and baby services. We don't have any children and young people's mental health beds in the two counties. So they're already organised primarily in a West Midlands footprint. So we come together then as different trusts to make sure that where we can, we try and keep people as close to home. But if they absolutely need that specialist provision, yes, we'd be working with partners to make sure that the right expertise was where it needed to be. And if that's further away, which is for the beds I've just mentioned, and then it's how do we make sure that that stays timely for people then to come back as soon as they can.
Because I do agree there's a trade-off, but if you're meeting the needs of the vast majority of patients, then I would think that would be a very good KPI anyway to have. And accepting that for the one or two cases where they are actually at the extreme of mental health treatment, that you would necessarily have to send them elsewhere. But I didn't get a feel for that in the three options, that's all I'm saying. But it may be something that's in the back of it.
I guess we've written the paper kind of just up to the level of level 2 specialist rehab. And one of the, I guess, first question we asked ourselves is, exactly your question. Do we have enough patients that are like this, that form a coherent group? And our answer is yes. You know, we've always got at least 15 patients who are requiring level 2 rehab but can't have it locally, and 15 is about the size of a ward, and it's made us think, look, we probably should have something closer, because the distribution of patients at the moment, it is far flung, and whilst they may be getting good care, what it means is we can't have a local model. Whereas if you're working with maybe one provider more locally, even if it's not exactly in the 2 counties, what you're then able to specify is, look, this is how we want it for our patients. You're able to set standards, set pathways, make sure they're well connected, and hold the provider to account. So that's our thinking around consolidating, at least at the level 2 level.
So are you saying there's a level above level 2?
Yeah, absolutely. So
I wasn't aware of that, sorry,
yeah,
reading this.
yeah. So part of what level 2 also does is take what's called step down from forensic pathways. So some people will be coming through a criminal justice route, so they'd have been somewhere like Rampton Secure Hospital, and they'll be coming down through medium secure and low secure settings, and often after that they'll need to go to a level 2 rehab unit.
Thank you. Councillor Tully.
Hey, excuse any ignorance that comes out of my mouth, but I wanted to double check that. So in the 3 options, you've got Hillcrest quite clearly mentioned, and I just wanted to double check that that's not the case now, and that would go to an external provider. So one of my questions was around external providers that do level 2 and how prevalent they are, and shall I leave it at that? Because there's others. But
There are a good range of providers that do level 2 rehabilitation, and we have patients placed in level 2 rehabilitation. There's a variability in the cost, and there's a variability in the quality and the outcomes. I think that would be fair to say. What we're entering into now, as we've ruled out Hillcrest, is an exploration of which providers are local enough, which are willing to have a discussion about consolidating and block contracting, and which can meet the standards that we'd require from a rehabilitation unit.
So that was what I was thinking along what Louis was saying around. Well, you had said West Midlands being an area. There's something quite different between being 150 miles away and being somewhere in the West Midlands, and if it feels like that's potentially, if it's prohibitive to create a unit that's fit for level 2 purpose, that a provider that you trust and that you have a good relationship with in that area feels like a compromise that is worth managing. And then the other question I had around Stoneboat is that, so obviously there's a time frame with all of this, and the big work's been done. Is that level 1 or level 2? And if it isn't those things, how has that happened that it is now done up but not level 1 or level 2? So
So within Stonebow, there's 3 wards. So it had 3 wards before, and the clinical decision was, okay, those 3 wards are about the right size and meeting the right kind of constituent. Let's rebuild them as modern wards. So the 3 wards, there's a ward for older adults with functional mental illness. That's things like depression or psychosis or severe anxiety, something like that requires an inpatient admission. There's a ward for older adults with organic problems. That's dementia like Alzheimer's disease and vascular dementia. And then there's a ward for working age adults in Herefordshire who've got an acute mental illness, something like acute psychosis, acute depression, or a personality disorder. And for the working age adult ward there, Mortimer ward, patients would be staying there typically less than a month. So they'd be treated for an acute episode of care and they go back to community care. The level 1 and the level 2 rehab, for the minority of patients, are probably only 10% of those who require ongoing care that's longer than an acute episode. They need rehabilitation.
Sorry, so that's neither level 1 nor level
No,
2 in the whole of Stonebow.
No, so that's acute care. So our I'd say level 1 unit, though it's not quite that, in Herefordshire is Oak House.
Okay. It's in the options, but obviously I've misunderstood.
That's
Thank
okay,
you.
sorry.
Councillor Stark?
Me again. I want to touch upon preventative services. I'm not sure whether this is the right forum or not to touch upon it, but it just seems to me that this redesign is about, once you've got the patient into the system, you're determining how you're going to treat them. I just wondered how much work is also going into trying to stop them getting there in the first place, because I would have thought that would be quite a essential part of this whole pathway analysis that you set out before us.
Absolutely. Obviously, I may bring Sue in. So, of all the mental health services that we provide, this is, I guess, the kind of tip of the pyramid. So this is for the smallest number of people. So most of the services we provide are actually about intervening with people when they've got a common or less serious mental health problem. So our talking therapy services, see around 10,000 people a year. So, and I guess a common misconception people have about mental health services, they're difficult to get into. There's a long waiting list. Well, in Herefordshire and Worcestershire, that isn't really the case. We've got an open door. There's a 24-hour helpline that people can ring. If they ring up and talk about their problem, they'll be designated to the correct type of service. That might be an emergency service they need straight away, or it may be redirected onto something like talking therapies or one of our community teams. So most of the work is undertaken at that level. Unfortunately, a smaller number of people, less than 1% of the population, will develop a serious mental illness, something like schizophrenia. Now, for those people, we also intervene early. So we've got an early intervention in psychosis service in Herefordshire, and that works with people who are just developing a psychotic illness. And the whole aim of that work is to prevent disability. For people who are developing a psychotic illness, trying to keep them linked with their friends, trying to make sure they keep taking medication, that they have psychoeducation, that families are helped deal with the consequences of mental illness, and that they gain or maintain employment. So we're very much working at that early stage. But, for all of that, there will always be some people who develop a more serious problem that needs more intensive support.
Could I just add on a little bit as well, just to say that I think we often, when we talk about mental health, don't potentially look at it through the lens of the depth and breadth of what we're talking about. So when we say physical health, we know that we mean heart disease, cancer, respiratory challenges. With mental health, we sort of put it all together and then we lose something about that really, really small number, but very, very poorly folk who may well live with schizophrenia, for example, for their entire lifetime. And we know that the health outcomes for some people, will be 15 years less than their peers in terms of their longevity. So there's something about that which is really, and when you were saying about level 1 of it, so when we're talking about some of these services like the acute bed in the Health and Care Trust, it is really small numbers. We therefore work really closely with our partners about what's that broader piece to try and keep people mentally well in their communities, what's that piece on resilience. And I'm just looking to you, Zoe, actually, because we've got a session coming up, haven't we, in the Health and Wellbeing Board, where we're going to go back round again on the best start in life as one priority for the council, and the other being very much about good mental health and wellbeing. And it's how does this then bolt in so that people who need specialist support can get it quickly, it's timely, and it does exactly what it needs to. But it doesn't work if it's not then interfacing with all the services that keep people well and make sure that people have got settled accommodation and they've got employment. And so that's the piece for me, is is how we get the moving parts and what is really quite a complicated set of pathways working, and what does that look like in prevention, because it does look quite different, I think, than perhaps it does for other parts of the system.
Just as an add-on to that, have you got a feedback loop? I mean, I'm assuming that you're trying your best to prevent these people getting into the level 1 and level 2 system as much as you can. But once they get there, do you do any analysis to see why they got there? And therefore feed that back to you, to your redesign of your preventative services? It just seems to me this should be part of the overall redesign aim of this, which is to reduce as much as possible the people that actually need this service in the first place.
Yes, sitting as part of the work that's happened to date, where a number of case studies and they were used as part of the early engagement. Matthew said we've got people with lived experience of these services, part of the redesign work, and they're part of the steering group. So yes, that learning, well, what could have made a difference? When would we have done it? How are we going to make sure that this particular piece of work responds to that is part of the way in which the options have been developed so far.
Thank you. You've mentioned pathways and also community quite a bit in the discussion and debate this afternoon. So looking at the proposed changes to the adult mental health inpatient and rehab pathways, how will these changes improve patient outcomes, and how will services like Cromwell House and Oak House be integrated into the new model to ensure seamless transition between patient and community care?
So, as I mentioned before, one thing that isn't as well developed in the two counties is a community rehabilitation offering. It's probably a little bit better in Herefordshire than it is in Worcestershire, because in Herefordshire we've still got what's called an assertive outreach team, which work with people that have high level intensity needs in the community. As we reduce the number of inpatient beds by closing Cromwell and reducing or closing Oak House, the staffing resource that's there starts to move out into the community to provide community based rehabilitation, so intensive support for people living in supported accommodation or in their own tenancies. And this provides a kind of step down from acute care. So for some of the people that we've had them as an acute admission, and at the moment we'd be discharging them back to care as usual in the community, a service like an intensive community rehabilitation service would step into that space and help the person make that transition, where they still needed to gain life skills at home with things like budgeting, managing a home, managing their medication, well, that kind of thing. That's where that service would fit in the future model.
And one of the things I was just desperately trying to find where I saw it is about community hubs, because we I think at the council think of community hubs as a completely different thing that you're saying in, it's on option 3, the further details. It says community hubs can be utilised across Herefordshire and Worcestershire to reduce travel burden. And I understand that the new national guidelines is relating to the community part of that, and that the hubs are the teams. Is that correct? Have I got that right?
Yes, that's right. We're referring to the community teams that we've already got based in hubs across the two counties.
Councillor Stark.
Yes. This is my final question. Herefordshire is very much a rural county.
Yes.
And when you get involved in a debate through the various rural forums, one of the issues that comes up is this hidden mental health crisis in rural areas and how we get to that. Again, I didn't see in any of the 3 options which one would be best in order to tackle that, or does it need to be addressed elsewhere? That's what I'm saying, because that makes a challenge in Herefordshire different from a challenge in Worcestershire to some extent. How do you get to the patients, as you said, to someone who's had schizophrenia for 15 years, sitting in an isolated hamlet, doesn't realise it, as you say, it impacts on their life, shortens their life? I don't get any feel from the three options how you're actually making that sort of position better for these sorts of patients in the rural areas.
I guess the options as we've set them out are they're primarily for patients we do know. So when somebody's needing rehabilitation services, these are patients that have already come to our attention. They've often and usually had many acute episodes. They've been into the Stonebow unit on a number of occasions, and we've identified, okay, look, this person's going to need longer working with them to get them as well as they could be. In terms of community accessibility, I guess over the past 5 years, we've had a good amount of investment from central government to develop our community services. So we've expanded our community offering, and a lot of the work we've done with the GPs is about ensuring that the door is as open as possible. So we accept 97% of referrals that are made to us from GPs for mental health. So it's more unusual to turn somebody with a mental health problem going through GPs away. And we were set kind of access targets as well. So one of the targets of the last government was that, you know, a third more people would receive mental health care in the community. And in both counties, we're far exceeding that. So we're 30% ahead of that target. So the evidence at the moment seems to be actually, okay, we are, at least in Herefordshire and Worcestershire, providing services that are accessible to people.
And I currently chair the Better Adult Mental Health Partnership, and so we've got really good conversations around that table. So Zoe and the team very much pulling through what is it that we need to know together so that we can be out with communities, ear to the ground, and then make sure that people know which door to come through. I think people will often say that they don't really understand mental health in terms of how you get the support. So that's the piece that we're doing in that space, very much through a partnership conversation. And I suppose I've been really struck actually, because I think a number of you may be aware that we've been accepted as a signatory for the Mental Health and Wellbeing Concord Act, Prevention Concord Act, and that's very much speaking to the agenda that you're talking about. And so we're doing some good work, and then we just need to scale up and do more.
Thank you, Sue. Before we go back to Councillor Gandy, can I just ask how much involvement have the primary care network been involved in this?
They've been intimately involved all the way along. So as the models have been, they've been involved in the consultation, they've been involved in the design, and as the model has proceeded, actually we've been out to the PCN to TCN to continue discussing it with them, and our Associate Medical Director in Herefordshire links personally and directly with all the Herefordshire PCNs.
That's good to hear. Councillor Gandy.
Yeah, just talking about the rural areas, because I happen to represent a very rural area. I think one of my concerns on the occasions when I had dealings with mental health group was that something when a patient has been in Stonebow and then been discharged, but is still being visited by one of your outreach workers, and this person was, and that wasn't the issue, but the person concerned was a hoarder, but not just a hoarder within their own property, a hoarder that extended far beyond their own property into the wider community. Having had dealings with your people, they don't seem interested. They don't seem interested, or they didn't seem interested in, they didn't seem to be joined up work. So basically, having spoke to your officer and said, you know, are you aware that this is going well beyond the home and is impacting upon other residents who it's affecting their mental health, the answer back was, well, that's not my problem. And in the end, as a council, we dealt with what went on outside of the confines of that person's property. But I was really surprised that there was no joined up working to try to work with the resident concerned about the fact that his impact of hoarding was impacting upon the wider community.
Thank you, Councillor Gandy. Did you want to say anything, Matthew?
Only to say, if any members are have questions about individual cases or are concerned, I'm sure either myself or Sue would be happy to take direct communication. All of our teams do and should work closely with local authority colleagues. So, if it hasn't happened in this case, I can only apologise.
Okay, thank you very much. Just one final thing from me, really. It's looking forward now. So we've got the phases of the programme in our report, and we also know from that there are 11 overall objectives in the programme. So I just wonder what specific key performance indicators will be used to measure the success of the redesign, and how will these be monitored over time?
Okay, so at the beginning of the programme, we set out the overall objectives, which are listed, I think, in section 9. Those are our primary lead indicators. As we start to work with when we've finalised the level 1 and level 2 model, we'll then set a set of secondary KPIs, which are things like overall length of stay, successful securing of tenancy, a range of social outcome indicators. It's probably slightly too early to set them yet, though, because we'd need to have gone to the end of selecting which option to determine the correct indicators. But they will be about determinants of kind of health and ability subsequent to rehabilitation.
Okay, thank you. Thank you very much. Any more questions from committee members? No. Any other comments from Councillor Gandy? No, you're okay. Is there anything you'd like to say, Zoe, or are you just happy to listen and comment if you need to? Sorry, I didn't mean to spring that onto you.
No, not at all. No, I've just been listening, but I think Sue's raised the issues in terms of prevention and rural access and the things that I would have come in to say in terms of inequalities and early prevention. So thank you.
Yeah, thank you very much. Okay, so we'll go to our actual recommendation, and the recommendation is that the committee note the report. I think we've done that, and decide upon any further scrutiny we wish to undertake regarding adult mental health provision in Herefordshire. And I think we may have a couple of things from Daniel.
I think the only thing I picked up from the discussion was a request from you to provide the committee with the Getting It Right First Time Adult Mental Health Pre-Consultation Engagement Report. Susan, if I might, I think I found a copy of that report. Was it from 2024? It was, yeah. I think I found a copy of that. I'll send you the link that I've seen. If that's the one, then I'll share that. No recommendation required.
Okay.
Yes, it was, because we had a number of engagement events and it came back into that, and then it went through to a number of committees. So I'm glad that was very tenacious. Well done. And then the other piece I picked up on was whether members would like to have the opportunity to come round and visit the Stonebow site.
Those were the two things that, but yeah. I think Henry perhaps will be doing that, will he?
Well, no, if the committee wants, would the committee like that to happen? Would they like that visit to take place?
Do you want to?
Sort of in theory. In that case, I think obviously we can make a recommendation, but since we've I've got the information to give to you, and
Yeah,
we can arrange the
there's no-
meeting.
there's no need, no.
There's no point. We'll
No.
note that in the minutes that we'll do that.
Yeah,
We'll provide you with the
they're
additional
actions, not
information.
recommendations.
And then if the committee wants an update on this, to look at this again in future, having received that pre-engagement report, having visited Stoneberry, if this is something that you'd like to look at again at some point in the future, then we can absolutely include that on your work programme if you wish.
I'm not saying we need to have a recommendation, but I did point out it'd be useful to have the 3 options set against the outcomes and the guidance around value, accessibility, humanity, equity. It doesn't have to be a recommendation, but if we get a commitment from the trust to do that, and then I think you might want to revisit the options once we've got that sort of analysis.
That strikes me as a sort of marker, really. So in that regard, I think if you're happy to do that, that strikes me as a recommendation and one that can be responded to quite quickly.
Yeah.
If it's okay with you, then what I'll do is I'll try and craft a recommendation during the course of the next item, and then you can vote on it after the meeting. If that's okay, great.
Okay, so are we all in agreement with that recommendation?
Thanks, yeah.
Yep. Everybody, thank you very much.
Okay, thank
And
you.
again, thank you very much, Sue and Matthew. It's been an interesting afternoon so far. I'm now calling a short adjournment, and the meeting will recommence in 10 minutes.
I'll go and get Mandy.
Sorry, I turned it on and turned it off. We're now on to item 8 on the agenda, which is All Ages Carers Strategy Action Plan and the recommendations of the working group. And we have Sylvia Nichols, who's joined us. She's online. So if she wants to add anything, feel free, Sylvia, to put your hand up and we'll come to you. But otherwise, we have in the room John Burgess, Commissioning Manager, and Manny, who's the Head of Service Living Well. Is that your title, Manny? Yes. Okay, so the purpose of this is to discuss and agree any proposed recommendations from the working group of the All Age Carers Strategy Action Plan. Gosh, these are such mouthfuls, aren't they? So we'll start off with any questions from Councillor Gandy. Would you? First of all, actually, we'll come to Daniel. Would you like to explain the recommendation?
Thank you, Chair. The committee decided to have a look at this this action plan last year. At a time when the action plan hadn't even been produced, it realised that it didn't really have much to contribute towards the strategy, and the action plan would be where, well, the action would happen, and where the committee might be more useful in terms of its input, particularly in your role as community leads. Because of that, because you decided that you preferred to do a more detailed piece of work with the officers, you identified correctly that the best way to do that would be in an informal working group, because that would just allow much more dialogue between officers and members outside of a formal committee setting. And as such, the meeting in which you discussed this was very fruitful, very productive, and but you agreed in that meeting that you wouldn't make formal recommendations. Instead, you would use that meeting to make suggestions to develop the action plan, and to discuss those within the context of the meeting itself. So the report that I've published here for you, rather than making a set of recommendations, it lists those suggestions that were tabled in the meeting and were agreed. I think at that meeting it was noted by those there that they found this a rather more fruitful way. Sorry, put my teeth back in. A rather more fruitful way of working with officers for this type of work. And as such, I feel that you've been a lot more swift in your contributions, and therefore a lot more useful in your contributions. But anyway, they're all listed there as the suggestions in Appendix 2, and the recommendation is that you agree those in the report.
Thank you, Daniel. Before we move on to that, can I ask any committee members if they have any comments, questions or concerns following the group meeting, which I must admit I found very productive, new way of working and a definite new way of thinking.
Yeah.
Councillor Stark.
I wasn't on the working group, but one of the concerns we always have is getting the voice of the person at the centre of all this heard, and heard particularly in the council and across all the other organisations where they need that support, that advice and guidance. I know that the voice of the carer can be heard through the Carers Link network. It can also be heard through the partnership board. But I just wondered whether there needed to be some sort of forums supported by the council that allowed carers in an informal way to post issues, advice, or even concerns or experiences they've had amongst each other, where they could actually share that and they could actually have that sort of discussion group, rather in a more formal or more structured way. I don't know what you think about that. That was one of the things that I thought was slightly missing from the actual working group's approach here.
I think this is a perfect one for John.
Yeah. Yes, interestingly enough, as a conversation that we continue to have, there are those routes, as you say, through the Carers Partnership or Carers Links. But in terms of, there's always going to be perhaps a struggle in terms of getting people with lived experience to join committees, depending on the time they take place, etc. So we are thinking about ways in which we can engage with carers in a larger forum. So exactly that. So there's an opportunity to feedback about what is taking place, but also an opportunity for people to feedback to us about concerns they have. So try and do it on a more, I suppose, a more informal way, but also looking at things like time constraints. You know, does it have to be? Could we do something perhaps early evening? Is there a forum taking place already that we could participate in? So it is absolutely something we're thinking about and aware of.
Any other questions from any committee members? No, nothing. Councillor Gandy, did you want to add anything?
Couple of things. Before I comment on the work that you've done, I just wanted to sort of advertise the fact that we are having an unpaid carers session at the Kindle Centre on the 9th of June, where there will be various workshops and talks and opportunities for carers to understand legal services that are available to them, complementary therapy, that sort of thing. So we are doing what we can. With regards to the work that's been done by the subgroup, I think for me, this is an occasion when I can honestly say that the Scrutiny Committee has recognised how important the all-age carer strategy actually is and how important carers are. And that's not just carers that we know about. It's those people who are carers and don't even recognise themselves as carers. And I think the action plan supports that. I'd like to thank those members of the working group for the work, the time that they gave up to carefully examine the plan and to add some really important suggestions for consideration by the Scrutiny Committee. And I'd like to thank the Scrutiny Committee for whatever you're going to be coming forward during your discussions this afternoon. And thank you.
Thank you, and I'm glad you reminded us regarding the event in June. The microphone's still on, sorry. You're still in the picture. No, that's it. Any other questions from no other members? Sylvia, you've got your hand up if you'd like to come into the conversation.
Yes, actually, it joins together both John's and Councillor Gandy's comments. One of the issues with getting carers to any event, like the one on the 9th of June, or even to a carers board, is that they can't relinquish their posts. They therefore need to have somebody come and replace them as their carer, just for them to come and contribute. And only this morning, one of the carers that had been to one board meeting, didn't attend the next, has issues with internet and all that sort of thing. And unless you take the personal approach and give them a friendly call, you are totally unaware of the problems that they have to deal with day to day. I'm aware that the event on the 9th of June has lots of interested people, but very few carers. And that purely at the moment is it's too far ahead for them to even think about going to an event. So I've been tasked today with trying to contact as many as I do have contact details for. Maybe it will be a chat, maybe it was a reminder, just to get them to come along. And so it's a struggle all the way down the line, but a worthy one, because the carers that do manage to participate do come up with really down-to-earth problems that they need solved and information passed on to. So I would put forward this recommendation of right across the board working from the base to the top scrutiny committee to keep these thoughts and actions in line. Thank you.
Thank you, Sylvia. I don't know whether Manny or John have any thoughts on that comment, or how we as the local authority can try and support it more. Manny's going to dive in. Thank you.
Yeah, just in addition to what John said earlier, we are, thinking about current forums that there are already. We're thinking about mimicking also the young carers subgroup of the Carers Partnership Board. They meet at a time that's very convenient to those young people. The leads that bring the information to the Carers Partnership Board, work in the evenings to be able to account for the timetable. So that's also part of our consideration. I think the other thing that we've been thinking about is how we actually recruit to the Carers Partnership Boards, and in fact all of the partnership boards that we have, learning disabilities, autism partnership boards, so that we are really clear on the commitment. We're supporting really from the outset in terms of things like training and information to carers, so they can make a much more informed decision before they commit. So we're working on that in the background, and then obviously understanding from them how they want to receive the support from us, both in terms of Sylvia's support as the chair, but our support as the commissioning function, in order for people to be able to contribute into those conversations and into those meetings and the subsequent decision making.
Thank you, Manny. And I think it's really important that everybody has the opportunity to have that voice, whether you're a young carer or an older carer. It is all ages, like we've said. Councillor Gandhi.
Just a quick point. I had the opportunity, sometime last year, to go out with one of the OT people to visit a carer and their care for a person in domiciliary care, and to chat to the carer. And I think certainly all of our staff that go out to people's homes, I'm sure they do, but I think it's really important that we recognise that it's not just about the person that's being cared for. It's about the quality of life and the needs of the person that is doing the caring. I know from my own experience when my father was very ill, everything was surrounding my father. Macmillan nurses and all of that, and everybody was always asking how was my father. I don't think anybody ever asked how my mother was, and I think that is really important. And I think if we take nothing more away from here today, it's important that when we talk to people who are caring for someone that we know, to not just ask how their relative or husband, wife, partner is, but to say, and how are you? Because that really is something that I think we sometimes fail to do. So I do my best wherever I go to make sure that I talk to the carer, who may not necessarily say, as I say, recognise themselves as a carer, but just to say, how are you? How are you getting on? How are you coping? What sort of respite are you receiving?
I think that's a really poignant thought and comment, Councillor Gandhi. Rebecca, Councillor Tully.
I'd be delighted if you'd all just call me Rebecca. That would be wondrous. Yeah, so I think the voice is really important, and where the voice can be heard, recorded, monitored, seems to me really important as well. I was going to note the action monitor and report on young carer support in rural areas, and I was struck by monitoring and supporting, and there was something else. There was another line where I was thinking this is a potential place. Training for identifying and supporting carers. I know it's almost impossible for some people to get to a partnership board, to get to a group, consultation, all of those things. And some people, it's not about getting cover. Like I know of at least 2 people who are caring for somebody with dementia. They are not even considering leaving that person's side, and they never will. But they are talking to people all the time, and their voice is in everybody that they're talking to and getting services from. So I think for me, some of this is also about unpacking the monitoring and the recording. So if they're not at this amazing event in June, where is their voice heard? and how do we trust the people that are working with them so that we can also hear their voice. The voice of somebody that has listened to somebody with lived experience is also really, really powerful, and I think that to me feels as strong as, you know, having one person in the room that's experiencing it right now. If you've got somebody in the room that really understands the issue and can share it, I'd be really happy to see some of that, how we're recording that voice in those actions as well.
Thank you, Councillor Tully. John, did you want to comment on that?
Just to say, I think that excuse me, it's always a challenge. I think this is the biggest challenge, I think, of capturing the voice, because there are so many people. Because across Herefordshire, we know there are 17,000 recorded in the census, but we know it's probably far more than that. People who undertake care and responsibilities, and as was rightly pointed out, many people don't even recognise themselves as undertaking care and roles. It's just what you do for your loved ones, and so it is an ongoing challenge and finding ways. I would like to add there's a lot of activity taking place to support carers at the moment in different areas. So the Mental Health Trust, they have a carers oversight group. They're doing an awful lot of work in terms of improving, putting in policies, doing work for carers, making sure that there's activity. And there are other groups as well. And I think bringing those different aspects, those different groups together to find the ways of capturing people's voices. We probably won't ever get it right, but anything that we can do to improve that and just find ways of channeling. And I'll just add, within the strategy itself, there was a letter that was provided from a carer. Sadly, his wife had died just before, but it was a very moving statement from his diary about the frustration, but then also the love which stands by the side of that, and that really captured, I think, the sort of what it is to be a carer for somebody over that time. So anything that we can do like that. So we do need to keep thinking to find different ways, but there is no easy answer, unfortunately.
Are you okay with that, Councillor Tully? Yeah, lovely, thank you. Any other comments from anybody? Sylvia, is there anything you'd like to add?
I just endorse the work that the council are already doing, because I know it's successful to have got so far already. And we are all mindful of what is required. It's strange that this morning I was contacted by one of the commissioners, who is Carolyn, in how can we ensure that all the boards truly do represent, and what boards are working really well, and how we can we start to emulate that. So I've had a half-an-hour discussion about that, and it's purely around more and more discussion, chat, friendly approach, that people feel comfortable, almost like having a little coffee and a chat before they feel they're able to move forward, even if it's a chat over the phone, even if it's an online chat, which is possible to get more together. So I think it's more of the same, and never forget what we're doing it for, or who we're doing it for, which is not just the person who needs the care, but the family and the carer that are actually in the midst of it all.
Thank you, Sylvia. And I think that is shouted loudly when you have your carers partnership board. I think everybody has their voice there, and it is an open space for anybody to ask anything, which is what we need. We need to have no barriers. Thank you. Any other questions or comments from anybody? No. Okay.
Councillor Thomas.
Oh, sorry. Councillor Thomas.
I was just going to say, you know, we're talking about a year ago, I was quite heavily involved with several foster parents, and they really did, in fact, both of those parents no longer foster parents, and simply because they talked to at various meetings, but nobody listened, nobody did anything. And I just rather hope that, you know, we don't give this sort of. It is very, very important that you listen to people, whether they may be giving the right statement, or maybe they're stating things you don't really want to hear. But it is very important, because they get frustrated. And as I say, two foster parents that I've been representing, they've just gone out of fostering. We've lost two. Good, they were very good.
And obviously fostering is caring, so that's something that I'm sure you'll take on board. Thank you, Councillor Thomas. Okay, so looking at the covering report, it recommends that the committee note the report, B, the committee endorse the findings of the working group report, and the committee receives an update in due course on implementing the All Age Carer Strategy Action Plan. Are we going to put a time to that? Are we going to suggest 9 months or something?
I would suggest that you just keep it in due course and come at a time that's ready.
Okay, thank you. So that will come in due course. Can I have a proposer and seconder for this? There we are. We've got all in favour? Yep. So there's nobody against or no abstentions. Thank you very much. Thank you. Thank you, Sylvia, for attending. Thank you, John and Manny. Thanks very much. If you don't want to stay, that's absolutely fine. You can go and do your other day job. Thank you. Nice to see you, Sylvia.
Thank you so much.
Bye-bye. Item 9 on the agenda is the work programme for 2024-25. So the purpose is to consider the work programme for this committee for the municipal year of 2024-25. And I'm going to ask Daniel to introduce it.
Thank you very much, Chair. Daniel Webb, Statutory Scrutiny Officer. We've recently completed a piece of work reviewing scrutiny and its processes. And although that report is yet to be endorsed by Council, one of the fundamental planks of that is that we explore different ways of working away from our committee-based system. As such, there are a couple of issues really sort of coming down the line that I feel that the committee needs to be aware of and give some thought to how it might respond and scrutinise those items. The first one concerns demand for adult social care, and this is a topic that Hilary Hall, the Corporate Director, has raised with the Chair and Deputy and the committee, and has asked the committee to put its head together to think about how it might usefully contribute to this priority for the council, the ever-increasing demand for adult social care, and how the council can mitigate and respond to that ever-increasing demand. We're proposing, given the new ways of working, to develop this as a task and finish group for the committee, or rather a task and finish group managed by this committee. This wouldn't necessarily be all of the committee members sitting on that task and finish group. It would be open to any member of the council who wanted to be on that group, but it would sit outside of the formal committee settings. If the committee is minded to do that piece of work, then I will bring a terms of reference for that piece of work to the committee in July for discussion, and then we would carry out that work informally during the course of the year. The second big issue that's affecting us at the moment is the reconfiguration of integrated care boards. The integrated care boards need to meet considerable cost savings from 2026-7 onwards, and have to present proposals to NHS England at the end of this month as to how they intend to meet those cost savings. Now, obviously, the Integrated Care Board deals with and manages a lot of health provision across Herefordshire, for which the local authority is either responsible, has an impact on, or has a stake in. So obviously, any of those changes to the reconfiguration of the Integrated Care Board is going to have an impact on the council and the services it provides. This is a developing piece of work. I don't have sight of those proposals. I'm not sure anybody here at Herefordshire Council yet has, but we will soon enough. Accordingly, I've sent you a document that was published recently around a blueprint for this, and I would urge you to read that document when you get a chance. And I would also urge you to look online for any analysis around that, because there's analysis emerging on the impact of this. This is quite a complex and big piece of work, and it will have profound impacts on the local authority going forward. So I would urge you to look at that, and I think at a future planning meeting we will have to ask ourselves how as a committee we're going to respond to that, even if as a committee you decide not to respond to it. So two big issues there. You have a work programme at the moment going on towards September. However, I would suggest that we meet at some point soon rather than later, and we have a look at that and how that manifests during the rest of the year.
I think that makes absolute sense.
Chair.
Councillor Gandy.
Can I just comment on the adult social care demand task and finish? I absolutely support what you're wanting to do. I'm not quite sure where the timescale is that you're looking at. My concern from the Directorate's point of view is that we've now been notified of a CQC visit, and I would not want any of my staff taken out of what we're trying to do at the moment to be prepared for CQC in order to participate in task and finish. And I don't think the task and finish would benefit if staff either couldn't attend or it was a rush piece of work. So what I would like to do, and I realise this is difficult because we haven't yet, or we might have done and Hilary might not have told me yet, we haven't yet actually received the date of when it's going to be. But it could be within, we submitted the information by the 2nd of May, and we've done all that. And it could be any time between then, 8 weeks, but it could be a little bit longer. So I'd like to suggest, but it is only a suggestion, ultimately it's your decision, that you might want to wait until we've had the CQC, partly because around the issue about demand, there may also be some issues that come out of the report from the CQC that you might want to include in that task and finish, which are weaknesses that there are within the Adult Social Care Directorate. And at this present moment in time, I would say, wouldn't I, there are not many weaknesses, and I've obviously seen the self-assessment, which is very good, but I'm sure when the CQC do come, they are going to find some things that they are not as good as perhaps they ought to be, and it will be really helpful for the task and finish group to pick up on those particular issues in general and see what they think we could be doing to actually improve in those areas. And it might mean that they still concentrate on demand, because an awful lot of what goes on in adult social care is affected by demand. But it might be there might be something else that also tips up in that review.
Yeah, thank you, Councillor Gandy. I did suggest that sort of timeline as well, but then with discussion, it was like, well, the officers already have everything prepared, so it wouldn't be much time for them to submit it to the committee. But Daniel's going to help us with that one.
Councillor Gandy, you said that we'd be notified of the inspection. Do we have a date for that now?
No, we haven't yet.
No.
Oh.
Zoe.
Yeah, I don't know if it's helpful for me to come in. So as Councillor Gandy said, we haven't been notified of the inspection date at the moment. The first stage is that all of the evidence has been pulled together and submitted, and then we'll get notice of that, which could be any time now, between now and September. So it makes it a period at the moment of lots of activity in terms of preparing for the inspection as best we can, so that we can showcase the good work that's going on. But I guess the timescales wise, it might be good to have the inspection first and then to have this piece of work afterwards, rather than them both happening twin track.
Yeah, thank you, Zoe.
They almost certainly will interview the chair of scrutiny. I would expect them to. If they don't, I'll be amazed if they don't. And there is no reason why you can't say that you were going to do this piece of work, but you're obviously thinking of leaving it until after their inspection, and that might actually, in their eyes, be a good thing. You know, I don't want scrutiny to be held back in what they say about adult social care. Obviously, I mean, they need to say it as they see it, but obviously, I also, with my hat on as a cabinet member, want us to be seen and as good a light as possibly we can. And I think examining us before starting the examination before the CQC gives the impression that you think there's a real problem there, which there might be, but I'm a bit nervous about it.
Yeah, just to add a bit of clarity, this discussion whether we should have adult social care on our agenda came in many months ago, way before we had CQC decisions, etc. So, you know, I think we've got to be flexible on this as committee. And Daniel, I think you want to add something finally.
I don't see a clash here. I think this all dovetails quite nicely. I mean, there's a long, you know, with the task and finish group, it's not just a question of we're going to do all this in July now. In July, we will bring a terms of reference, which will be little more than this is the scope, this is the topic, and this and these are some of the questions that we might ask in that. What would then follow from that would be a scope and a work programme where we'd look at that in more detail. Given the work programme that we've got at the moment, we have our May meeting, here we are. We have a meeting in July and that's all agreed, and the topics that we will look into that, including terms of reference for this. So given that very little happens at the local authority in August in terms of committee meetings, I couldn't see this piece of work starting in earnest until September anyway, even if we started at pace now.
Yeah. Zoe?
Yeah, I totally take your point in terms of timescales. I just wonder whether CQC inspection will give us areas to look into in terms of deep dive into, and therefore the sequencing of it, to have the CQC inspection first and the feedback and then this piece of work might make a lot of sense for us, because it will direct that terms of reference and where we might want to look.
Thank you again for your input. Any final words, Daniel? No? Okay, so Councillor Davis.
Yeah, I just wanted to ask, do we have, I know the CQC inspection is due between now and September, but generally we're not going to have a report back from CQC, even though we'll have an indication possibly from what's said and what's done. But do we have a forecasted date for the report to come back in?
They give my understanding is they give a verbal report at the end of the week that they've been here, so we will know where we are, and the written report comes fairly soon after that. I think it's about a week or so. It's not long after that. The difficulty that there's been, because as you know, we haven't had CQCs for local authorities for about 20 years, so this is a really new thing. And if you go onto their website, you'll find there's not that many that have been put onto the website, and that's because a number of local authorities have questioned their score, and also they only update the website once a month anyway. So there are a significant number that have been inspected but haven't yet got onto the website because they have queried their score. But we would probably know fairly shortly after. I would think we would know by the end of the week that they've been, from the presentation that they will give to the council as to where we are as a local authority, and that would give you a rough idea of the areas that you need to concentrate on, I think.
Zoe, you wanted to add further?
No, I was going to say, in terms of, I think we'd have a really good sense from the focus groups and the staff engagement and the presentation that's given to them in terms of that verbal feedback about where we might want to look closer in terms of those areas that we want to improve and go further with.
Okay, thank you. Councillor Gandhi, yeah. Okay, so So we're now going to look at the recommendation for the covering report recommends that the committee agree the draft work programme for Healthcare and Wellbeing Scrutiny Committee in Appendix 1, and obviously it is still subject to monthly review as the basis of our primary focus for the remainder of the municipal year. And we note the programme for the other scrutiny committees and identify opportunities for collaboration and alignment for work. And while we're on that, we also have the forward plan that we align our work to, which is also as an appendices. And the other item I would like to thank officers for is keeping our recommendations made by this committee a live document. So thank you. So can I have a proposer and seconder for Councillor Davis? Thank you. Anybody else would like to oh, there we are. Got two seconders, either Councillor Dykes or Councillor Thomas. Okay, so item 10 on the agenda is the date of the next meeting, which is Monday the 28th of July at 2 o'clock. So it is now 15:49 and I'd like to thank everybody for attending and we'll close the meeting. Thank you very much.
Thank you.